Hello, everyone, and welcome to my Grand Rounds presentation. I have Oscar, and Oscar is a 59-year-old male. He lives at home with his spouse, Amelia, and he has one son named Everett, and he's a newly proud grandfather. He's a retired physician for over 20 years, and he was diagnosed with idiopathic Parkinson's disease 2 years ago, and he's now currently in stage 2. Reviewing some of his additional case history, he is on 2 medications that are just managing his symptoms for Parkinson's, including just like his motor issues. These ones will help with the dopamine deficiency and shaking. And he was also noticed to be having some attention and sequencing issues. These were some patient reported outcomes. And he was able to monitor his errors and self-correct them. With his voice, he's noticed that over the past year, it started to change a lot, and that he's noticed that it's starting to get soft and raspy. He feels like he's understood by others, but his wife and other communication partners feel like he's a little bit more difficult to understand. His chief complaint is that others cannot always hear him all the time, or he is not always understood. And for therapy, he would like to be able to be understood during enjoyable tasks and ensure that his grandchild can be able to hear him when he is reading or singing to him. To fully treat our patient to the best of our abilities, we're going to need a whole team. And so we are going to need an ENT neurologist and an occupational therapist. The ENT will help check for additional laryngeal pathologies. And of course, he will be needing to see the ENT before we can more than likely do full treatment. But it's just always nice that he is able to just double check everything and make sure that there's no other pathologies being involved, even though Parkinson's, it's less likely that would be the direct cause of any of his vocal issues. And the neurologist, of course, will help manage medications and just if there's any other additional new trials or anything that can help manage the shakiness or anything like that, that will help with speech as well. And of course, occupational therapy will be very important for those fine motor movements. And as well as a physical therapist as well could be helpful for some of his gross motor movements, but mostly what we will be targeting will be fine motor. All right, so for Oscar's subjective assessments, I have wanted to focus on behavioral qualitative patient-reported outcomes, which would be the Voice Handicap Index 10, and the voice-related quality of life. And the voice handicap will show us a lot of how it's affected maybe his participation in other realms in that way. And also the quality of life will show how this has emotionally impacted him and how it also can affect participation and everyday activities can be affected. And so we also want to look at his cognitive and communicative skills because this will translate to when we're in therapy with him that he will need to be able to focus on exercises and executive functioning with being able to execute the exercises correctly and just his everyday memory in life. I would want to use the Montreal Cognitive Assessment and Training assessment because it is highly regarded. We will be able to get a baseline. And for more of our other objective measures, we will need to do oral motor exam and a cranial nerve exam to measure for dysarthria. And that would be more of our perceptional analysis of it. And more of our standardized analysis would be doing the Frenchet to see what kind of dysarthria he has. But as we all know, it is hypokinetic dysarthria that is associated with Parkinson's. But just to be fully clear, you have all the documentation you need. It is important to do your full rundown. All right, so more on the auditory perceptual side, during the patient interview, we will collect a lot of how we're seeing the weakness affecting his voice and just how it's used in connective speech. And the same thing for the Kate V has more of a key things it is being said to see what kind of consonants that we're maybe seeing some more weakness on or breathiness during sentences. We can rate him on a more in-depth scale to see how severe we believe he is on all those kind of categories. All right. And for laryngeal function, we're going to be using the Pratt to announce for jitter and shimmer. or the Visi pitch as well, to see fundamental frequency, capsule peak prominence. And also during this, we can use some easy onsets that'll be used during the assessment process of just how he can hold out E and ah and different things along that matter. Now seeing how well that can translate into, okay, what did he do best? And maybe using that in therapy first. And the same for aerodynamic analysis, using spirometry, that is his breath intake and volume. And that is going to be very important for Parkinson's because they have weak lungs, muscles, and maximum phonation time, and seeing if there is a huge discrepancy between S and Z, seeing if there's more problems with the phonatory side of it, or if it is mostly a respiratory issue. And then his phonatory threshold pressure. All right, and to do some imaging, we will be doing a flex stroboscopy using a flashing light to see how the vocal folds are moving. This will be important to see if there's any vocal paralysis, any kind of improper closure along those lines. We'll use the Valley R to grade that stroboscopy. Now, while we got the flexible scope in his nose, I would suggest also if we want to do a thorough assessment, a FEES, because he has Parkinson's, and most likely you will see a lot of swallowing difficulties with people with Parkinson's. Might as well kill two birds with one stone and do some swallowing assessments on him as well after we are done watching vocal fold movement. All right. And then just to cover our bases really well, sometimes the rigid scope can see things better than the flexible scope can, especially if we have the epiglottis isn't moving how it needs to. That might be hard on the FEES because it's going to be harder for it to clear and show a clear image. Yes, the rigid scope can also maybe see things inside the back, more towards the back of the tongue that we can't necessarily see on the flex. All right, so for differential diagnosis, so let's just pretend we didn't know he had Parkinson's right when he came in, and there was no neurological whatever, and that we're mostly just thinking of it perceptual wise. Even if you're looking at perceptual wise, if you're comparing it to muscle tension dysphonia, it is going to be almost completely different symptoms and signs. Because with hypokinetic dysarthria or just with Parkinson's, perceptually, again, if we didn't know all the cognitive stuff was happening, we didn't already know it was hypokinetic dysarthria, we would already hear a lot of weakness and not necessarily strain. Now, strain can happen compensatory strain, but more than likely, they're going to have a lot of weakness and a lot of soft, not very loud at all. That is going to be less likely that we would see any kind of symptoms that would go with muscle tension dysphonia. So that's why I would immediately take it off the list, even though it is very common. So it is good to cover your bases. Also, vocal fatigue. Now, vocal fatigue is going to be a lot higher on our list of this is very comparable to hypokinetic dysarthria perceptually. Everything is pretty much there except for the strain, and vocal fatigue, you see a lot more pain. Now with Parkinson's, I feel like they will experience pain more in different areas of their body, more motor-wise, gross motor-wise, rather than just specifically in their throat or with that strain. But yes, you will see a lot of hoarseness and all those things, but it is more likely going to co-occur with hypokinetic rather than it being the main factor, because we do have to now, if we're factoring in that cognitive aspect, it cannot just be regular vocal fatigue. There has to be something greater going on. So now we understand, okay, there's something bigger. It's a neurological problem. And okay, so it's affecting nerve 10, the vagus nerve. Going through this list, we say, okay, hadn't had a stroke, hadn't had an infection, nothing like that. We have to narrow it down to, it is a progressive disease. We know it's worsening over time. He's saying his voice is getting worse over the course of a year or so. So that is a very big factor to, okay, it's progressive. Something worse is happening over time. Now, when we think about it, if we know it originated in the basal ganglia and it's a dopamine deficiency, it is more than likely, if not exactly, pointing to hypokinetic dysarthria associated with Parkinson's dysphonia, because it hits every single one of these criteria. Even though all these symptoms seem very similar to these neurological conditions, it's the location that can distinguish it rather than anything else, because we know that specifically Parkinson's has a deficiency in dopamine, and it is in the basal ganglia. And it is not confused with hyperkinetic dysarthria, because that would be tense muscles and spastic movements. This is going to be more your flaccid and fatiguing like muscles. This is not, so that those two are complete opposites in that way, even though they both occur in the basal ganglia. All right, so looking at some of his goals that I had planned for him, we're going to be working a lot on vocal intensity. And I feel like a great way to do that would be to be reading aloud and maybe a children's book to practice for his grandson. And just working on regular conversational speaking tasks. So that would be my goal 1. And then my goal 2 would be focusing on completing a program like Speak Out or LSVT. And because those have been shown really great evidence to improve, with the community aspect, to improve certain symptoms of Parkinson's disease, because they both focus on being loud and speaking with intent. And for my third goal, it'd be focusing on EMST, because that lack of breath with his voice is going to really contribute to that softness. And so we need to improve his muscle strength in his respiration to be able to have a more loud projecting voice. And then I included, for his vocal hygiene, it's not going to necessarily focus on strain. It could be compensatory, but more than likely, again, we're going to see those fatiguing muscles. I really want to focus on drinking water for him and superficial hydration, because he has swallowing issues. And I understand that we can make a whole slew of different goals for his dysarthria and swallowing, but for now, this is where we're at. But he will need to intake that. I'm assuming that he would want to avoid drinking water or thin liquids. And so even with maybe some increased thickness in his liquid, he'll be able to drink more, so that way we can keep the vocal folds nice and hydrated. All right, so for his comprehensive treatment plan, for the first day of therapy, we're going to see, okay, what is he semi-able? We're going to be counseling and saying, how is this affecting you? And what is really important to you? Because that's what we want to focus on. And we want to focus on what for, and we'll be doing that in assessment as well. But really, when we start getting into therapy, this is what it's all going to be for. And then maybe if we get to the end of it, because that'll be the most of our session, if we get to the end of it, we can talk about some tools and technique strategies, get him started, get his foot in the door about what therapy is going to look like. And then for frequency and duration, now every single program, LSVT Loud and Speak Out, are going to have their own type of frequency and duration. But for just our one-on-one sessions, I at least want to see him 1 to 2 days a week for 45 minutes at a time for over the course of 12 weeks. But like I said, they both require different things. It can be different for whatever he chooses that he wants to do. Also, looking at his semi-ability, we'll want to see what program we think would be best for him. Would Speak Out more suit his life, or would LSVT? Because if he's retired, he doesn't have a lot going on, and he really wants to get better fast, LSVT might be his better option. Speak Out, more of a relaxed flow of things. So just depends. And then we can see what kind of exercises might work best for him. And then for discharge, it is, with this progressiveness of his disease, it is going to be preference to whether, after he finishes his program, whether he wants to maybe continue at the rate and intensity that he is doing it, or maybe take some time off, come back later. It's recommended that he come every 3 to 6 months after the program is finished to reevaluate. But every patient is different. Every patient has different needs. Every patient has different kind of family situations. We need to be understanding that he might not come back within that specific time period exactly, but being able to adapt to bringing him back for a plan of maintenance and what we are expecting to do within the future. Because this is going to be, for now, the rest of his life, that he's going to be having to go to speech therapy, OT, doctor's appointments, on and off. Yeah, it's really up to the patient. This is going to be a long road ahead. So the structure of how our sessions are mostly going to go is we're going to start off counseling. We're going to talk about how has your cognition been? How's your swallowing been? How has your vocal hygiene been? So cover all the basics. This is all kind of homework review and teaching, reteaching, and teaching again. And especially with those cognitive things missing every once in a while, we're going to have to do a lot of in certain ways. And we want to make sure that he's adhering to his work from home plans with LSVT or Speak Out. That's why I put both the option up there on my goals, because I wanted to see which one, not narrow them down to those two programs because those are the two best evidence-based, but that he at least has the option to choose which one he feels best suits his life. And to just recap just certain topics so that way that we're not just recovering goals and strategies and exercises that they've already done in group therapy. We want it to be different for our therapy. So just having a little quick chat about that, and then just asking him how he's doing in the EMS team, and different counseling questions, concerns can be answered, and then practicing some reading or structural conversational tasks, which we can get from Speak Out or LSVT, but I will discuss that in the next slide about how also we can implement that. And then just wrapping up with just the feedback and how to practice at home again. All right, for exploratory muscle strength training, it is going to mainly focus on his muscles and getting them stronger, just like it says. And by using a little tube that he can restrict the pressure or the resistance that is be putting on, and it can make, as he feels stronger, increase the pressure. So it is feeling like it's strengthening the muscles, just like you would when you're lifting weights. You're lifting 20 pounds on each side, then you add 5 more when you feel like that feels too light. Same thing for exploratory strength training. And we want to find the correct resistance that would work for him. There are 2 different kinds. And so if they can't feel like they can start off already on the blue one, which is a little bit harder, we can pull them down on the green one, which starts off easier. All right, during structured or conversational tasks, I want to make sure this is going to be the real patient-centered care. And we're tailoring a lot of these interventions towards him and his interest. So that's why I talked about wanting to maybe do the children's book for one of the structured reading tasks. During these tasks, we want to focus the most on making it natural and increasing loudness, endurance, and breath control. And I also just provided some different options that we could do to incorporate his different interests that he had told me about in our patient interview. That was like golfing, fishing, and reading to his grandkid, and just some different things to do with that. All right, so let's go over the programs a little bit more in depth. First, the Lee Silverman treatment. The Lee Silverman voice treatment, loud specifically. There is another one that is for occupational therapy or physical therapy. That's not the one we want to do. We want to do loud. And so this is referred to as the gold standard by a lot of physicians or speech pathologists out there. And you're going to notice with the Lee Silverman, it is going to be very high intensity and frequent treatment. That's why I was referring to it, saying that if he was retired and wanted to really work on this, getting better faster, or maybe his condition was maybe a little worse off, he would need to do more frequent visits. The frequency of this would be 4 days a week, 4 times a week, lasting 60 minutes each. And for our one-on-ones, it can be a little bit different depending on where you're at, if you're outpatient or how that would be. And it's going to be a total of 16 sessions. Mostly with LSVT, you're focusing on thinking loud. Being loud, even though you think you're being too loud, it's not loud enough. But so they do some warm exercises. This we're going to hear your me, my, mo, moo. That is sometimes some patients like it, some patients don't. They find it a little bit annoying sometimes. But we're really going to focus on the awareness of the voice and going through that as their own perceptual analysis is very important to how this treatment is going to be executed. And just the hierarchy task being that same to the principles of motor and movement, we're going to be focusing on maybe some consonant or consonant vowel, syllable work, and then words, phrases, sentences, and then it progresses that way. It's the Van Riper approach, as we would call it in the principles of motor learning. And then going to sustained phonation, working on that breath support. And then directional pitch exercises, working on the variety and intensity of the pitch, and working on functional speech task, asking somebody their name, having a real conversation with somebody, just not some phrases you would never use in real life. And then generalization of the skill, which would be practicing it within the real world. And now see, speech out is very different because it's going to be a little bit lower intensity of therapy and frequency. So more to 3 to 4 sessions per week is a total of 12 sessions together.
and the refresher schedules every 3 to 6 months. They have different time spans of when you're supposed to come back, but best practice 3 to 6 months. And Speak Out's going to focus more on speaking in intent rather than just being really loud. This is going to be a lot of at-home work. They're sent home a workbook and that they could work at home, maybe do some more tailored approaches. They might not think the me, my, mo, moo helps them as much in real life, but maybe some more conversational stuff. So it's good that they can tailor it to themselves in that way. And then, of course, being incorporated within the loud crowd, that is also their community that they're a part of, that can help with that awareness. And just, I think it's really helpful for the emotional aspects of it, having other people that are going through what you're going through. And just daily practice. Yes, they want you to practice twice a day on your own. So both of these are quite a lot of work, but it is very, very beneficial in the end. All right, so that's concluding the end of my presentation. I'm really hoping that with these tailored approaches, this patient-centered care, that these activities and these programs will really see a benefit in the goals that we've developed for Oscar, and that he sees an overall better understanding and clarity in his speech whenever we are finished with our main majority of our sessions. Overall, hoping that this increases his quality of life and gives him more time and better quality to spend with his family.